Hi, this is Jennifer Harvey. I am the breast section chief at AIRP, and I'm also professor and head of breast imaging at the University of Virginia. We're just going to do a quick review of benign breast calcifications. BI-RADS divides calcification morphology into two categories. Today we're just going to look at the typically benign. The first thing I want you to do is look down this list, and I want you to notice that the morphology that you pick is basically saying what you think the calcifications are due to. So for example, if I pick coarse or popcorn-like, I'm basically saying, hey, I think these calcifications are due to a degenerating fibroadenoma. The exception to this is round. So we're going to look at round calcifications last. Let's start with skin calcifications. These occur in sebaceous glands and are most common in the folds. So cleavage, inframammary fold, as well as the periareolar region. Because they're in sebaceous glands, they're going to typically be grouped. They will be lucent-centered or round. I like this one because it looks like a little footprint. I want you to notice the shape of the lucent-centered calcification. It's not very round or oval. It's what we would call polygonal, or some people say geometrically shaped, so it can have a little bit of funny angular margins. Here's a patient with lots of skin calcifications. Again, some are round, some are lucent-centered, and the other thing to notice is that the ones that are lucent-centered have a very fine rim. These are not very thick like the rim type calcifications that we're going to talk about in a minute. One thing that should clue you in that their calcifications you're looking at might be in the skin is this. So notice that the calcifications that you see in the CC view look almost the same as the ML view. In fact, it kind of looks like I went into Photoshop and flipped it upside down. I promise you I didn't, but that's what it looks like. Why is that? So when calcifications are in the skin, they're always going to have the same relationship to each other. Like a tattoo, right? Whichever direction you look like, it's going to look like a butterfly or a rose or whatever your tattoo is. If calcifications are in a lobule, then depending on which projection you look at, they're going to have a different relationship to each other. So when they look the same in every projection, think, oh, maybe those are skin calcifications. Vascular calcifications are usually pretty obvious, right? You've got that long winding road of parallel train track type calcifications. However, when vascular calcifications are early, particularly in a dense breast, they could be really hard. So do you see these little fine calcifications in that linear distribution? Now in this case, you can kind of make out that it looks like there's another wall nearby, implying they're probably vascular. But if that breast was a little bit more dense, you might have to biopsy those because they could be DCIS, those linear calcifications. I guarantee you right now that you're going to biopsy vascular calcifications someday. So it'll happen. Coarse popcorn-like calcifications are typically due to degenerating fibroadenomas. This is just a close-up. Doesn't that look like popcorn? Okay, what I want you to notice though is the earlier one. Do you see how the calcifications are forming at the edge of the mass? And the mass has kind of fuzzy margins. That's because the fibroadenoma, as it's involuting, is going to have sort of more indistinct margins. The calcifications are going to form in the periphery of the mass. So you can kind of make out the mass here in that dense tissue. Do you see how the calcifications are forming in the periphery of the mass? So And over time, they're going to get coarser and denser and brighter. Yes, there might be one or two more each time, but mostly the calcifications are just getting coarser, denser, brighter, sort of coalescing. Notice at the end that the mass is a little bit smaller because it's degenerating. Yeah. Large rod-like calcifications, sometimes you'll hear us also call them secretory calcifications, or you might even hear the term plasma cell mastitis. These are due to duct involution. So as the breast involutes with age and menopause, first the lobules get reabsorbed, and that's when the breasts become less dense and often eventually fatty replaced. The milk ducts also undergo involution over time, and if those ducts have some debris in them, that can be inflammatory, and that can cause some periductal or intraductal calcifications. Some people say they look kind of cigar-shaped as well. Typically, these are going to be bilateral and symmetric, but they can be unilateral and even in one area of the breast sometimes. Now, because these are due to duct involution, they're usually going to be seen in older women, like in their 70s. If you think that a patient in her 40s has large rod-like calcifications, be really careful. Now, maybe she went through early menopause or something, or had breast radiation, that can do it too, but just be really careful if they're younger women. Rim calcifications are due to fat necrosis. So when you injure fatty tissue, it heals by liquefaction necrosis, which is really inflammatory. Your body tries to wall that off. Do you see on this side, there's a lot of lymphocytes, macrophages, histiocytes reacting to that inflammatory oil. It's trying to wall it off. So eventually it forms these sort of eggshell type calcifications. Notice how much thicker these are than the dermal calcifications that I showed you a few minutes ago. Now, these little calcifications like that, those are usually due to just incidental trauma, like soccer balls. When you have larger rim calcifications, those are usually due to more significant trauma, like surgery, as in this case, or reduction mammoplasty. Sometimes due to bad trauma, like a car accident. Because this is part of a healing process, these rim calcifications are one of the ones that can actually go away with time. This was a few years after a reduction mammoplasty, and you can see most of those rim type calcifications have resolved. Dystrophic calcifications are a variation of rim type calcifications. I know sometimes we use dystrophic as like a wastebasket term, but it really actually applies to a very specific type of calcification. Dystrophic calcifications are almost always going to be seen in a lumpectomy bed, often after radiation. Sometimes you'll see them with just benign surgical biopsies or really bad trauma, like burns to the chest. I've seen those, but almost all of them are going to be in or near a lumpectomy bed. Notice that they will often have these irregular shapes, but still have lucency in the middle. That's because a lot of this is just healing fat necrosis in that surgical scar. Milk of calcium is due to an enlarged, sort of blown out lobule that gets full of fluid, that develops some debris in the fluid, and then that debris calcifies and settles in the bottom of those parts of the lobule. So think of this as like sugar in a glass of iced tea. When you are looking at this from the side, you're going to see a meniscus. So that's what you're going to see on the true lateral views. When you look at this from above, it's going to look more powdery. So that's how that's going to look on the CC view. And in fact, sometimes you don't even see these on the CC view. So the clue to milk of calcium is that it's changing shape in two views. Here's a great example of milk of calcium. So do you see the meniscus on the true lateral? See how it's powdery on the CC? Now, one thing I want you to notice is that it's still smudgy looking on the MLO view. So when you're getting magnification views, you want them to be in the CC and ML. Okay, LM is okay too. That's still a true lateral. But don't get your mags in the MLO because you won't be able to tell if those calcifications are milk of calcium. Milk of calcium is one of the causes of not seeing calcifications in the core biopsy at histology. So let's say you do a biopsy, there's a specimen radiograph that shows calcifications, and your pathologist is like, yeah, I don't see those. And they might see like a nice cyst at histology, but there's no calcifications in it. So milk of calcium does not stain with H&E. It's calcium oxalate. But it is birefringent with polarized light, which means you polarize it and you see all these cool, like glow-in-the-dark dots on that imaging. So most pathologists know to look with polarized light if they're seeing cysts but no calcifications. Sutural calcifications, those are usually pretty obvious. You're looking for knots and ties and rings, so usually that's pretty self-explanatory. Now, round calcifications. So these are almost always benign and due to fibrocystic changes, but not always. So just like a round or oval mass on mammography, most are going to be cysts or fibroadenomas, but some of those are going to be cancers. So let's figure this out. First, notice that round calcifications tend to be very, very round, like peas. Yeah, so they all kind of have very similar morphology, shape, size. When they are new, you have to be worried that they could be cancer. So which one of these do you think is due to DCIS? Did you make up your mind? I hope you picked that one. Actually, if you pick that, that's okay too. And actually that one too. So I'm sorry to be tricky, but my point here is that even though these have a very benign round morphology, they're new. So just like if you had a new round or oval solid mass on mammography, you got to biopsy that. Same with round calcifications that are grouped at mammography. So how do we manage round calcifications? Think of this again as like a round or oval circumscribed solid mass on a mammogram. You're going to use distribution and prior studies. If the calcifications have a benign distribution, you're going to give that a BI-RADS 2. If it has a scary distribution, segmental or linear, you got to biopsy those. Makes sense, right? If they are grouped and it's the first mammogram, remember almost all these are going to be benign. Just like a probable fibroadenoma on a first mammogram, BI-RADS 3 those. If they are new or more in number, increasing, that's going to get you a 4. So when you have round calcifications, you're going to biopsy them if they have a scary distribution or are new or increasing. Okay, that's the end. Now I would welcome you to practice. You can take a self-paced test. Just go to Socrative.com. Go to student login. You don't have to make a login and password. That just takes you to this page, and you're going to put in my teacher's room, which for this quiz is Harvey Benign Calcs. I don't ask for your name. You can take it as many times as you want. So have a lot of fun with this. Thank you.